Hello everyone. Welcome back to the series of lectures in hematology. Today we will be moving on to myeloid neoplasm, and the first of the lot is acute myeloid leukemia. So, whenever we speak about leukemia in adults, so what exactly is leukemia? Leukemia refers to the malignancy of the blood where there is a clonal proliferation of the WBC and WBC precursors in the bone marrow, and then it spills over to the blood and can involve other organs as well. So, leukemia in adults, 80% of the cases are your acute myeloid leukemias and 20% of the cases are your ALL, okay, which is your acute lymphoblastic leukemias. So, let us understand the definition of AML. So, there is a clonal proliferation of the WBC and its precursors in the marrow with involvement of blood and other organs, and the most common type of AML is your myeloblastic picture. Okay, acute myeloblastic leukemia. So, let us understand the epidemiology. So, AML is basically a disorder of the elderly with an average presentation of 60 to 70 years, right? So, this basically means an average presentation of the 6th or 7th decade, but AML can be found in any age group. Many a times nowadays we are seeing a lot of young AMLs in 20s and 30s as well. Right? And when we speak about the gender predisposition, AML is more common in males than in females. So, let us understand the risk factors for acute myeloid leukemia a little bit more in detail. So, most of the time there are no factors which are known. Most of the time there are hereditary factors, and sometimes even environmental associations have also been found. So, what are the hereditary conditions or syndromes which are definitely associated with an increased risk of AML? So, this can be because of defective DNA repair mechanisms. Okay, so this can be because of defective DNA repair mechanisms. Then it can be because of syndromes like Diamond-Blackfan syndrome, Fanconi's anemia, disc keratosis congenita. So, these are some of the inherited syndromes which have an increased predisposition to AML. Apart from that, we have certain germline mutations which have been identified which can be associated with AML, which includes a SEPA and a GATA2 mutation. Two other syndromes which are congenital syndromes, chromosomal abnormalities which are associated with an increased risk of AML include Down syndrome and Noonan's syndrome, right? So, these are some of the important inherited or hereditary conditions and factors which can predispose a patient to AML. Apart from that, you have to definitely consider environmental factors which includes radiation exposure, alkylated hydrocarbons like benzene exposure, smoking and drugs. So, when we speak about drugs, it's very important that the drugs which are used in cancer chemotherapy in itself has risk of secondary AML. So, what are the drugs? So, topoisomerase inhibitors. Topoisomerase inhibitors have a risk of secondary AML after 1 to 3 years of use of topoisomerase inhibitors. Then we have alkylating agents. When there is a risk, the risk is after 5 to 6 years of using an alkylating agent. So, remember, two groups of drugs very important, and the years after which a secondary AML can present. Apart from that, certain hematological conditions in itself can predispose to a secondary AML, which includes a myelodysplastic syndrome, myeloproliferative neoplasms like polycythemia vera, essential thrombocytosis, and even paroxysmal nocturnal hemoglobinuria. We have learnt in the PNH chapter that PNH can be associated with aplastic anemia, and sometimes it can progress to a secondary AML as well. Okay, so this is about the important risk factors which are associated with AML. So, before we move on to the understanding of what is AML, its clinical features, classification and so on, let us understand the basic difference between myeloblast versus lymphoblast. So, myeloblast and lymphoblast are both precursors and of the myeloid as well as the lymphoid cells. So, when you look at a peripheral smear, how will you know this is a myeloblast or a lymphoblast? So, as you can see, the myeloblast is usually 15 to 20 microns in size, and it is slightly larger than lymphoblast, which is 10 to 18 microns in size. Okay. Secondly, the myeloblast usually has a round and oval nucleus, which is the same thing that you can see even in lymphoblast. Okay. Now, when you speak about the chromatin, in the appearance, it has a very fine chromatin, a myeloblast. Can you see that the pink pink portion is the chromatin, which is less well organized, whereas if you see a chromatin of the lymphoblast, this is clumped chromatin. Okay, the chromatin are in the form of clumps. So when you speak about the nuclear membrane, we find a very fine nuclear membrane, as you can see here. It's a very thin nuclear membrane in a myeloblast, but when you speak about the nuclear membrane in a lymphoblast, it is usually thicker nuclear membrane. Then what are the number of nucleoli? You can see that there are around 2 to 5 nucleoli in a myeloblast, whereas the number of nucleoli are lesser and it's only around 2 in a lymphoblast, and more granular appearance is seen in myeloblast. Can you see that in the cytoplasm there are large number of granules which are found in a myeloblast, and you can find these rod-like structures which are called as Auer rods. Rod-like structure called Auer rods are found in the myeloblast, but you find a blue agranular clear cytoplasm like a blue sky. This is what we see in a lymphoblast. Okay, so this is some of the basic differences which we have to know when we speak about the appearance between a myeloblast and a lymphoblast. Okay, so myeloblasts are bigger, they have more finer chromatin, you can find a more granular cytoplasm, right? But in a lymphoblast, here it is scanty, sky-like appearance cytoplasm, there are no granules, and the nucleoli are lesser in number, and they have a thick nuclear membrane, and they have a more clumped chromatin. Okay, fine. So now that we have understood this basic difference, let us understand the classification of acute myeloid leukemia. So there are 2-3 classifications that we have to know. The first one is the WHO 2016 classification of myeloid neoplasms, especially with germline predisposition. That means if they have a certain set of genetic abnormalities, then they are classified according to this. So the first part of the classification of your AML is myeloid neoplasms with germline predisposition without a pre-existing disorder or organ dysfunction, right? So they have a germline predisposition, but they do not have any pre-existing organ dysfunction, or they do not have any pre-existing disorder. So this includes AML with SEPA mutations, AML with DDX4 mutations. Then we have myeloid neoplasms with germline predisposition and pre-existing platelet disorders, right? So platelet disorders and germline predisposition, and you develop a myeloid neoplasm on top of that. So we remember RUNX1 and ETV6 under this predominantly. Then myeloid neoplasms with germline predisposition and other organ dysfunction including GATA2, bone marrow failure syndromes, telomere biology disorders, Noonan syndrome, Down syndrome, right? So this basically means those group of myeloid neoplasms which arise along with other organ dysfunction or arise along with other syndromes like Noonan syndrome, Down syndrome, telomere defects or bone marrow failure syndromes. Okay, so this is how you classify the myeloid neoplasms if they have a predisposing germline predisposition, if they have a certain group of mutations. Now, how do you classify AML according to the WHO 2016 classification? I'll just run you through this table because this table is very important. It may not be easy to remember everything, but we will try and attempt to remember the important things out of this. So, first is your AML with recurrent genetic abnormalities. Okay, so AML with recurrent genetic abnormalities is the first type under the WHO 2016 classification of AML. So what are the 3 recurrent genetic abnormalities that you definitely have to remember? Remember translocation 821, translocation 821, which is RUNX1 and RUNX1T1 translocation, then AML with inversion 16 and AML with translocation 1616. So these are the 3 important translocations you have to remember as AML with recurrent genetic abnormalities: translocation 821, inversion 16 and translocation 1616. Okay, now why is this particular entity AML with recurrent genetic abnormalities important? Because if there is a patient, you have found that he has AML and you find that he has any of these translocations when you do a cytogenetic study, translocation 821 or inversion 16 or 1616, then this basically means that this patient can be classified as an AML irrespective of the bone marrow blast percentage. Okay, so if he has bone marrow blasts which are low, you don't find so many blasts, but you find any of these genetic mutations, then this patient is classified as an AML irrespective of the bone marrow blast percentage, and that is why you have to remember this very, very clearly. Okay, then we have APML with PML RARA is the second part of the classification. Okay, so APML with PML RARA. Alright, then what are the other portions of the classification? You also remember AML with mutated NPM1 with SEPA and AML with mutated RUNX1 under these. Then third is AML with myelodysplasia related changes, and fourth is AML not specified, which includes minimally differentiated without maturation, complete maturation AML, monoblastic AML, erythroid leukemia, megaloblastic leukemia, basophilic leukemia, pan-myelosis or associated with myelofibrosis. Then fifth we have myeloid sarcoma, and sixth we have myeloid proliferation related to Down syndrome. So most of the patients with Down syndrome have a predisposition to AML. The most common defect in Down syndrome is TAM or a transient abnormal myelopoiesis, or you can have myeloid leukemia with Down syndrome as well. Okay. So this is about the WHO classification. Seems to be very, very confusing, but just let us look at the most important points you have to remember. So when it comes to the WHO classification of AML, remember the first one is AML with recurrent genetic abnormalities, and the important mutations you have to remember are 821, inversion 16 and translocation 1616. And why is this important? Because you can diagnose them as AML irrespective of the bone marrow percentage of blasts. Then we have APML, PML, RARA, then AML related to MDS or myelodysplastic syndrome. AML not specified has these different types. So in the next slide you will understand that these types are the one which was initially described in the FAB or the French American British classification of AML, which was based on the morphology of the different types of blasts which can be found in your AML. So that entire group has been classified as AML not otherwise specified under your WHO classification. Okay, then we have myeloid sarcoma and AML related to Down syndrome. So clear? So this is about the WHO 2016 classification of AML. Now let us understand the FAB classification system, which you would have learnt in your pathology classes as well. Okay, so this divides it in basis of the appearances and the staining. So M0 is undifferentiated AML. M1 has a greater number of myeloblasts, okay, greater number of myeloblasts, but they are minimally differentiated, less than 10% differentiation, right? So can you see the image? You have huge myeloblasts, okay. M2, again the myeloblasts are greater in number with differentiation more than 10%. So more than 10%. So this is also a myeloblastic leukemia. The myeloblast percentage is more than 10% in the marrow, but more than 10% are also differentiated, right? And the NSE staining, which is your neuron specific enolase staining, is less than 20%. AML M3 under the French American British classification, remember, is APML, Acute Promyelocytic Leukemia. Very, very important. So AML M3 is acute promyelocytic leukemia, where you have increased promyelocyte with hypergranular cytoplasm, and you see the presence of Auer rods. Okay, so the presence of Auer rods, the presence of hypergranular cytoplasm, and the presence of promyelocytes, very, very important. APML is AML M3, right? So if you just go back into the WHO classification, this is what we are seeing. AML with minimal differentiation, AML without maturation, complete maturation AML, and then we have the APML. So AML M0, 1, 2, 3. Okay. AML M4 has predominantly monocytes. Okay. So acute monocytic leukemia, right? So that is AML M4, and in your AML M5, the monocytic cells are more than 80% with NSE positivity, and they are differentiate. Okay, so they are differentiate. Then AML M6 has more than 30% myeloblasts, and erythroblasts are also present, and M7 is an acute megakaryoblast leukemia. So AML M6 is an erythroblastic leukemia, more of RBC precursors. M7 is more of platelet precursors, megakaryoblast leukemia. Okay. So this is about your FAB classification, which you try and understand more in detail in the pathology classes. Okay, so out of this you have to remember that M3 is APML, M6, M7 erythroblastic and megakaryocytoblastic, monocytic is M4, okay, and APML definitely AML M3, right. So this is exactly what we saw here, right. So here you have AML with minimal differentiation, AML without maturation, complete maturation AML. Then we have your monoblastic monocytic, myelomonocytic leukemia, erythroid leukemia, megakaryocytoblastic leukemia, right. So this is about the FAB classification. So what all have we understood till now? We have understood AML basically stands for a clonal proliferation of the WBCs and WBC precursors in the marrow, and it can progress to involve the blood and other organs as well. Then we have understood what are the predisposing factors. Then we have looked at the WHO 2016 classification and the FAB classification of AML. Alright, fine. So let us just revise the certain important points which I had highlighted. So we have learnt about AML with recurrent genetic abnormalities. So why is this important? Because if you have a AML patient with any of these mutations, then you classify them as AML irrespective of the bone marrow blast percentage. Okay, fine. So what are those inversions? Translocation 15-17, translocation 16-16, inversion 16 and translocation 8-21. Okay, translocation 15-16 is the one which is associated with APML or translocation of PML RARA. Alright, okay. So let us understand the clinical features of AML, right. So AML is basically an acute myeloid leukemia. So what do we mean by that? So we mean that since this is an acute myeloid leukemia, you can have acute onset of symptoms. The symptoms are usually less than 3 months. So the patient begins to deteriorate and symptoms are usually less than 3 months. So it's very, very acute in nature. So either you can have a pancytopenia kind of picture or you can have a hyperleukocytosis kind of picture, and the pancytopenic picture is usually more common in type of clinical manifestations, right. So pancytopenia means what? All the 3 cell lines can be involved. So you can have anemia, you can have leukopenia, you can have thrombocytopenia. So if you have anemia, what are you going to have the clinical manifestations as? You will have fatigue. You will have unexplained fatigue. Okay. So fatigue is the most common symptom of anemia. Thrombocytopenia can result in bleeding manifestations. So they can present with epistaxis, they can present with ecchymosis, they can present with bleeding in the internal organs. You can have petechiae, right. So these are the symptoms with which they can present. Okay. So the average hemoglobin level in AML is usually around 8. So they may present with anemia of around 8, and an average platelet count that is usually seen is around 15,000 to 20,000 platelet count. Then you can also have leukopenia, and depending upon the degree of leukopenia, it can predispose to different types of infections. So the patient may have a low grade fever, patient may have evidence of infections as well, right. So this is the most common manifestation in the form of a pancytopenia kind of picture. So when you do a CBC, patient presents with these vague symptoms, you do a CBC, you find pancytopenia. Some of the AML patients can develop a hyperleukocytosis. What is the reason for that? The reason being that all of the myeloid progenitor cells, the malignancy has completely replaced the marrow. The bone marrow is not able to curtail the cells and entire blasts are out into the periphery. So the peripheral blood itself will show a large amount of blasts and you can have hyperleukocytosis. Okay. So whenever there is hyperleukocytosis, they can be resulting in an increased viscosity, and because of this increased viscosity, they can have slowing of the blood. You can have predominant CNS manifestations in the form of confusion. You can have pulmonary involvement, which can cause blockage of the pulmonary arteries resulting in breathlessness and so on. Okay. So this is a little rarer presentation of AML. Now apart from this, because of bone marrow expansion and severe malignancy affecting the bone marrow is hyperfunctioning, and hence you can have bony pains. The bony pains are predominantly found over the sternum, over the vertebrae. Okay. So this is how you can have bony pains. What is characteristically absent in a patient with acute myeloid leukemia is that you will not find evidence of lymphadenopathy. Okay, so lymphadenopathy is a characteristic feature of lymphomas and it is not found in acute myeloid leukemia. Now let us look at the other manifestations which can be seen in AML. So one is myeloid sarcoma. So what is myeloid sarcoma? So this is basically an accumulation of the tumor cells. The accumulation of tumor cells which basically present as mass-like lesions. They present as mass-like lesions and they are usually found where? They can be found in any part of the body. For instance, this myeloid sarcoma can be found in the extradural space and it can even cause compressive myelopathy. It can cause a compressive myelopathy, right? So, the tumor cells can aggregate and form mass-like lesions which we call as myeloid sarcoma. Then certain important characteristic features of your AML M4 and M5 is the presence of gum hypertrophy, hepatosplenomegaly and a predisposition to dental abscess. Okay, so these are some important questions where MCQs can be tested. AML M4 M5 is associated with gum hypertrophy, hepatosplenomegaly and dental abscesses. Then AML can involve the skin. It presents as violaceous skin lesions predominantly in the extensor aspect of the limbs and this is what is referred to as leukemia cutis. So there can be evidence of skin involvement as well. Then hemorrhagic complications and disseminated intravascular coagulation. Hemorrhagic complications and DIC is seen in which type of AML? Again, this is an MCQ point. It is found in APML or AML M3. Very, very important, right? So gum hypertrophy, dental abscesses, AML M4, M5, APML or AML M3 is associated with hemorrhagic complications and DIC. Then AML can also involve the eye. It can result in retinal hemorrhages. Okay, fine. So this is about the myriad clinical manifestations of AML. Now that we've looked at the clinical features, let us move on to the diagnosis. So how would you diagnose a patient of AML? So what will you find on the CBC? So as we had discussed prior, the CBC will be associated with pancytopenia kind of picture. So there may be evidence of pancytopenia, right? So there will be evidence of pancytopenia and sometimes you can also have evidence of hyperleukocytosis. Then a very, very important finding is the presence of the myeloblasts in the peripheral smear. So let us look at these images one by one. So what is this image showing? The image is showing myeloblast, which is basically a precursor of the WBC. So you can see that there is an increased nuclear cytoplasmic ratio, right? So these are the myeloblasts. Okay, so there is an increased nuclear cytoplasmic ratio with immature chromatin, nucleoli and some granules. What is the second image showing? Again, this is a myeloblast and you see these rod-like structures. This is your Auer rods. So in which type of AML is Auer rods very common? Auer rods is very common in your APML or your AML type 3. Now, what is this image showing? Here you see that this is also a myeloblast, but you see this increased granularity and you may see the presence of multiple Auer rods as well. So what exactly is this? This is your APML or AML M3. Then this is an MPO staining of myeloperoxidase staining of AML. So this is the type of peripheral smear findings that you can expect in AML. Now, what are the different things that you want to do when you consider the evaluation of a patient with suspected AML? So history. What are the things you would like to look on history? So in history wise, how are they going to present? This is just going to recapitulate what we have learnt till now. You will find increasing fatigue or decreased exercise tolerance because of anemia. There can be evidence of bleeding manifestations, right? You can find evidence of bleeding manifestations, bleeding from unusual sites, DIC, thrombocytopenia, especially in APML. Then it's history of fevers or recurrent infections because of neutropenia. And then comes certain important things in history which you really have to watch out for. If there is history of headache, visual disturbances, non-focal neurologic abnormalities, always think of leukemic infiltration into the CNS. This is a very, very important. Okay, so never forget or sideline the neurological disturbances with which an AML patient can present. Then always look for organomegaly, especially in patients with AML M4, you can have evidence of early satiety because of splenomegaly. Then you will have to also take an important family history because of certain syndromes which can be associated with AML like Fanconi, Bloom's, Cosman syndrome, ataxia telangiectasia, and so on. Then history of cancer in the past, exposure to alkylating agents, radiation, topoisomerase inhibitors, occupational exposure to smoking, benzenes, aryl hydrocarbons, radiation exposure, and so on. Okay, so these are the most important points you have to remember about the comprehensive history taking which has to be done in a patient with AML. Then, what are the things you want to look for when you look at the physical examination, right? So, when you speak about the physical examination, you have to look into the performance status, you will have to look into ecchymosis, oozing from IV sites, all of this may be part of DIC, presence of thrombocytopenia, fever and tachycardia, signs of infection, papilledema, retinal infiltrates, cranial nerve abnormalities. Again, never forget CNS infiltration of the cells. Then poor dentition, dental abscess, we had discussed this, AML M4. Gum hypertrophy, again because of leukemic infiltration into the gums, again in AML M4. Skin infiltration or nodules, leukemia cutis. Then lymphadenopathy, very rarely it can be seen, but do not mention that as the first point. Back pain, lower extremity weakness, this can be because of a myeloid sarcoma compressing and causing weakness, or it can be bony pains of AML as well. So this is about the important examination findings. So when we come to the various tests and radiological studies that you want to do in a patient with AML, you will have to do a CBC, you do the basics including the electrolytes and your LDH, your hepatic enzymes and so on, clotting studies, viral serologies, and then you will have to do a bone marrow aspiration and biopsy to see the morphology. You have to do certain special stains, you will have to do the CD markers, and you will also have to do a cytogenetic testing, right? Molecular studies for NP1, SEPA, FLT3, all of this has to be done. Why? This is done mainly because to prognosticate the AML. Then you may also have to do a chest X-ray, and you may have to place a central line because you may have to give chemotherapy, right? Dental evaluation, lumbar puncture, screening MRI, all of this will be done based on the symptoms that the patient is having. So this is about how you do a comprehensive history, physical examination and the test that you want to order in a patient with AML. So let us understand a little bit more about what all you want to do on the bone marrow examination for the AML patient. So first is when you do a bone marrow aspiration and cytology, definitely in an AML you will find evidence of blasts, correct? Then you have to do certain stains which includes the myeloperoxidase stain which I just shown you in the previous slide. Then you have a Sudan black staining. Then you will have to do NSE stain which is more positive in AML M4, 5, 6. Then we have periodic acid SCIF which is more common in M6 and M7. These type of stains are basically used to identify the morphology of the blast which may be present. Then you also have to subject the bone marrow sample to immunophenotyping. Immunophenotyping means to identify the CD markers to exactly identify what type of a blast cell you may be dealing with. So myeloblasts, what are the CD markers? CD13, 33, 117 and HLA-DR. Then promyelocyte CD markers, CD13, 33, megakaryocyte, CD41, 61, right? So this you will learn a little bit more in detail in pathology classes, but this is the reason why you should be exactly understanding what all you have to do and why these CD markers are important. So when you do a bone marrow, you definitely have to do a cytology and staining and you have to do a immunophenotype. Then cytogenetics. So then you will have to do a genetic analysis and try and understand what kind of translocations are there and what is the reason for that, because this helps in prognosticating the AML patient, right? So this is again a very important table. This is the European Leukemia Net Risk Stratification Score for AML. So you may not be able to remember everything, but try and remember the favorable risk factors. So remember which chromosome or mutations have favorable risk factors. Translocation 821, which is RUNX1, RUNX1T1, inversion 16 and translocation 1616 are usually considered to have a favorable prognosis. Where had we seen these same numbers? We had seen this as a part of AML with recurrent genetic abnormalities, correct? So AML with recurrent genetic abnormalities usually has a good prognosis. Then remember mutated NP1 without FLT3, okay, without FLT3 ITD mutations. So if FLT3 or ITD mutations are present, then it automatically becomes a intermediate or high risk. So remember, a mutated NPM1 and biallelic SEPA mutations. So if you try and remember this group, then it becomes easy. Anything else you can just rule out and say that they are not favorable prognosis. Okay, right? So if there is a mutated NPM1 without FLT3, but so if you can just see here, mutated NPM1 with FLT3, all of this, or AML with a complex karyotype, many of the monosomies, all of these are adverse risk factors. Okay, clear? So it's not very easy to memorize this table. Try and remember the salient features. Okay, so this is about the various tests and how do you prognosticate a patient with AML. Now let us move on to the treatment of acute myeloid leukemia. So one important word that you have to remember here, the treatment is called as the 7+3 regimen. Okay, so the treatment of an AML depends upon the age, it depends upon the performance status of the patient and comorbidities. Right? So if this is a young patient with no known comorbidities and the patient is able to tolerate the high dose chemo regimen, then the regimen that is given is called as the 7+3 regimen. So it comprises of the induction phase as well as the consolidation phase. In the induction phase, you give 7 days of cytarabine daily infusions along with 3 days of daunorubicin daily infusion, and this is what we call as the induction phase. The 7+3 cytarabine and daunorubicin. And after that, you move on to the consolidation phase. So when you move on to the consolidation phase, what do you have to do? After the induction phase with the 7+3 regimen, you have to repeat a bone marrow examination. And when do you say that the patient is in remission? The patient is in remission when the bone marrow blast cells are less than 5%. But now, in this era of molecular diagnostics, we do not look at only the blast percentage. If the blast percentage is less than 5%, we look for something called as minimal residual disease or the MRD, and we target an MRD of less than 0.01%, and only if the patient has achieved this MRD of 0.01%, then you go ahead with the consolidation phase. So induction phase is 7+3. Repeat a bone marrow and then you see the MRD for your 0.01% or less, and you go ahead with the consolidation phase. And consolidation phase can be either with a hematopoietic stem cell transplant or with high dose cytarabine based therapy. So young individuals, if they are been counseled and they are okay for a stem cell transplant, then the consolidation is brought about with a hematopoietic stem cell transplant. But it's not as easy as this. Many of the patients will be unfit, and for high-dose chemotherapy, in such patients, you give an azacitidine plus venetoclax, which is a BCL2 inhibitor. This therapy is given for unfit patients. So this is another flow chart which is basically from Harrison's itself. So if this is a favorable risk factor, then you do an induction therapy with cytarabine and daunorubicin, and consolidation with your IDAC, which is high-dose cytarabine therapy or stem cell transplant. If not, then in advanced risk factors, you may have to go for investigational therapy, right? And if there is no MRD achieved, or if the bone marrow blasts are still more than 5%, then you consider a relapsed or a risk-refractory AML, right? So certain new drugs which are used in relapsed refractory AML includes gemcitabine, ozagomycin. Okay, and FLT3 inhibitors, which includes midostaurin. So these are some of the newer drugs used in the management of AML. Now that we've learned about the treatment of AML, a certain subtype requires a special mention. So what is the subtype which requires a special mention? That is the APML, which is Acute Promyelocytic Leukemia, or the AML subclass M3. Okay, so as we all know, this is a translocation 15-17, and why does it require a special mention? Because it has a good prognosis. It has a good prognosis, and the treatment line is also slightly different. So what are the characteristic clinical features which an APML patient is going to present? The APML patient is going to present with bleeding manifestations, predominantly bleeding manifestations because of DIC in an young individual. Okay, so bleeding manifestations with DIC in a young individual. you have to think of APML. Now, when you do the peripheral smears, there are certain noteworthy clinical features which you have to remember. So, one is the presence of these fagot cells. Fagot cells are basically large bilobed nuclei or buttock-shaped nuclei which are found within the cell, right? Apart from that, second is there is a large amount of granularity. Can you see here? Heavy cytoplasmic granulations and the presence of multiple Auer rods. Multiple Auer rods is a characteristic feature of APML or AML-M3. Okay, so this cleft which is there within the nucleolus or a bilobed nucleus is a characteristic feature of fagot cells in APML. Okay, fine. Now, what is the treatment, right? So, the treatment is also noteworthy because it is slightly different from that of AML. In low risk individuals, the treatment is with the help of ATRA along with arsenic trioxide. ATRA basically stands for All-Trans Retinoic Acid. Okay, so All-Trans Retinoic Acid along with arsenic trioxide forms the main treatment of APML. Okay, so this is the major salient important points about APML. So with this, we have come to the end of our discussion on acute myeloid leukemia. Thank you.